This is a presentation on Alzheimer's disease by Caitlin, Stacy, and Lauren. We will talk about the disease along with its ocular and visual issues with a neuro emphasis. Alzheimer's is the most common form of dementia. Dementia is just a general term for memory loss and other intellectual abilities serious enough to interfere with daily life. This disease accounts for 60 to 80% of dementia cases. Alzheimer's is a progressive disease with 3 main steps. The first step is just a mild dementia, where a person is still able to function independently. They might have memory losses beginning such as forgetting familiar words or locations of objects in their house, and they should not need any additional help outside of just finding misplaced objects and values and a little help planning and organizing. The moderate step is usually the longest phase. A person will begin to forget facts about themselves. They might have confusion over what day it is, and personality changes may begin to occur. Paying bills might be difficult. The person might begin to feel a little moody or withdrawn and might be found lost or even wandering. The last step of Alzheimer's is severe. Serious memory and cognitive changes can inhibit the individual's ability to care for themselves, and communication and motor involvement is also involved. At the final stages, the patient will require full-time, around-the-clock assistance with daily personal care, and might even lose the ability to walk, sit, and even swallow. The main pathophysiology of Alzheimer's begins in the brain and the nerves. Throughout the disease process, the brain tissue begins to atrophy and even shrink, while the ventricles begin to enlarge. As the disease spreads through the cerebral cortex, personality changes begin. Deposition of amyloid plaques and clusters of protein fragments and neurofibrillary tangles cause an inflammatory response. Advancement of the nerve cell continues, and eventually, memory may become non-existent. On average, those with Alzheimer's live for 8 to 10 years after diagnosis, but the terminal disease can last as long as 20 years. There are 2 main things found in Alzheimer's brains, and those are the plaques and tangles. Plaques are just deposits of a protein fragment called beta amyloid that build up in the spaces between nerve cells. Your body produces these protein fragments normally. However, in a healthy brain, these protein fragments are broken down and eliminated. In Alzheimer's, the fragments accumulate and form hard insoluble plaques because they are not broken down. The tangles are the secondary component, and they are twisted fibers of another protein called tau that build up inside the cells. Tau is a part of a microtubule which helps transport nutrients and other substances from one part of the cell to another. In Alzheimer's, this protein is abnormal, which causes the tubule structures to collapse, and you are no longer able to transport those substances, and therefore those nerves are no longer communicating and working.
All right, and so now we're going to talk about Alzheimer's and its specific effect on vision. So 43% of the patients complain of visual disturbances. The areas that are attacked are going to include those that affect motion blindness, depth perception, color perception, and contrast sensitivity. Patients are also capable of experiencing illusions, misperceptions, and misidentifications. It should be noted that the illusions are not true delusions. It's specifically damage to the visual system. Hallucination is different from a visual perception, and sometimes they are accused of having hallucinations. Specifically, patients may complain of the following ocular signs and symptoms. These include decreased VAs, can be blurred vision or inability to read in general, a decrease in visual fields. The most common affected is the inferior field, light sensitivity, pupillary response to mydriatics. This is a controversial finding that patients who are dropped with tropicamide specifically dilate 13% more comparably to other elderly. This is not a diagnostic test, however. There may be a defect in saccadic eye movements. There a delay or overshoot/undershoot. They may have issues identifying and naming objects. And they also might have a incapability of reading and writing. So there's been a lot of research on ways that doctors can change their eye exam to better serve those with Alzheimer's who come into their office. And these are just some ideas that have been gathered to help make it easier. So to start, it would be a good idea to take a really detailed history, asking the patient have they had recent issues with memory loss, just losing things and difficulty with their daily living. When you begin the exam, it's probably a really good idea to use really clear instructions and be prepared to repeat them as their memory may be going already. During VAs, some of the patients may not be able to recognize the words or the letters or numbers that are being shown to them, so it's a good idea to use a tumbling E for more moderate to severe cases. When prescribing the RX, it's best to give a progressive lens for their moderate reading distance or their moderate working distance is most important, such as walking or finding things in their home. Because they have an issue with eye movements, such as saccades, a progressive lens is better than a bifocal because the bifocal might get in the way. It's important to do an OCT if you're thinking it might be Alzheimer's. This, as we'll discuss later, can show nerve fiber layer thinning. When you're performing the ASEG evaluation, it's really important to assess for dense cataracts because cataracts can throw off color perception more, and it really is just best to have the patient seeing the absolute best that they can, and so eliminating things that we can eliminate would help with that. In fundoscopy, it's been found that the vessels in the back of the eye can be thinned, and this is correlating with vessels thinned in the brain also. It's also been found that drusen is denser in the periphery in Alzheimer's patients. Another thing as mentioned earlier was they may complain of field loss, or you might just run one just because you might be thinking it's Alzheimer's, and in that case you would see an inferior field defect. And it's really important to follow up with these patients every year just to see how far they're progressing and what changes you can make in their life to make things easier. So just moving on, this is more than just reduced vision. More complex things that might be found in patients with Alzheimer's includes contrast sensitivity, color discrimination, as was mentioned already, visuospatial perception, visual processing speed, attention, and in feature recognition of complex objects such as faces. So as they were able to notice things before, now they cannot. This is a direct result of neuropathological changes in the retina and visual cortex. Since these visual symptoms can occur early, it is possible that you can detect these quicker. And all right, and moving on.
So as Caitlin mentioned, it's past just decreased visual acuity. It has to also do with the retina and the visual cortex. There's not a lot of information as far as the visual cortex and how Alzheimer's disease affects it. There's two theories. One is that the changes could arise either from a bottom-up effect from degenerative disease in the retina and the optic nerve, or from a top-down change, which is from the higher order visual areas in the visual cortex. A decrease in surface area of V1 and an increase in receptive field size in Alzheimer's may account for changes associated with vision, such as reduced visual acuity and decreased contrast and deficiencies in color. There are also emerging studies showing neurofibrillary tangles, same as what Lauren mentioned earlier, and plaques in the primary visual cortex as well. Because the visual defects are often reported as one of the first signs, the measurements of the changes in the visual cortex in Alzheimer's patients might improve our understanding of how the visual system is affected and could cause earlier treatment and diagnosis. So first I'm going to talk about how the Alzheimer's affects the retina. The beta amyloid deposits have been found in the eye
just like they can be found in the brain. The beta amyloid deposits can be found in the layers of the retina, which can lead to cell death. The cell death may lead to axonal degeneration of the optic nerve, reduction of the retinal ganglion cells, decreased nerve fiber layer, photoreceptor loss, retinal glial cell loss, and vascular changes. Thinning of the retina may include a loss of either the photoreceptor layers in the outer nuclear layer or cells in the inner retinal layers, which would be the ganglion cells, the horizontal cells, the bipolar cells, and the amacrine cells. The transparent nature of the eyes during our exams allows for direct observation of the progressive changes in the amyloid development within the retina as well as the brain. Future development of high-resolution optical imaging can help us early diagnose Alzheimer's, and then that helps us with the response to therapies and non-invasive imaging of the retina. So here are just a list of different tests that have been studied to early detect Alzheimer's, and these are directly related to the eye, the retina, and the primary visual cortex. First is visual field maps. These are cortical representations of visual space that provide a highly structured measurement that might be used to detect subtle neurodegeneration. A better understanding of this progression of pathology within the visual cortex could help drug research and therapeutic innovation. There are patterns of changes across the 4 hemispheres that may reflect a more uniform effect of Alzheimer's on the visual pathway. Such changes may underline the visual symptoms that we see early in the disease. So because the visual field maps are highly structured functional responses in the cortex, the measurements of Alzheimer's patients can be done non-invasively. They may prove useful for demonstrating very subtle changes in the Alzheimer's disease patients. So as you can see in our picture, there is green and gray. So what that is showing is the white-gray matter segmentation for a young, healthy adult and someone with mild Alzheimer's disease. They are T1 weighted 3D images. The gray-colored overlay represents white matter, and then the gray regions are the gray matter. White regions are white matter not segmented in the cerebellum. Gray matter is grown from the boundary of the white matter and bounded by the cerebral spinal fluid. So A is a healthy young adult, and then B is a aging left hemisphere, and then C is a mild Alzheimer's disease right hemisphere. So note in the Alzheimer's disease patient how the cerebral spinal fluid space has greatly increased compared to the youthful hemisphere. Next is VOSP. This is impairment of the visual perception in Alzheimer's measured using the visual object and spatial perception battery. This is a test that divided into objects and space processing associated with temporal and parietal pathways. Neuroimaging shows atrophy in Alzheimer's patients that extends posteriorly to the parieto-temporal lobe, leading to impairment in dorsal visual perception. Visual perception is a primary indicator of this disease. This test shows ventral and dorsal visual processing. Subjects are first screened for acuity with cards containing a degraded X and must indicate whether or not the X is present. So here's the first part of the VOSP. This is the object perception. What they do is the patients go through and test first an incomplete letter, so they have to tell what the letter is, and then they have to look at a silhouette of an object and name it, and then you move on to space perception. Space perception is the second part of the test. This just includes counting dots, finding a position of a dot within a box, finding numbers within a box, and counting cubes that are stacked in different positions.
VEP, ERG, is another way to detect Alzheimer's early in the disease process. The ERG pattern and that visually evoked potential test are commonly used to test in ophthalmology and optometry, and they just estimate the bioelectric function of the retina and the optic nerve. The patterns that can be observed in early Alzheimer's include a delay in the N35, as you can see to the right side of the screen, the P50 and the N95 components, and that can also be accompanied by just a general reduction in the amplitude of those peaks. A reduction in the B wave can also be noted, and that is just due to the reduced number of ganglion cells that are present in the early Alzheimer's retina. It is important to note that while these findings have been reported in a number of clinical studies, they have not been proven to be contributed to Alzheimer's disease, and patients with Alzheimer's disease have normal VEP and ERG findings that do not meet these qualifications. Therefore, this cannot be used to confirm a diagnosis, but it should be used just to help you determine if there is a possibility of early Alzheimer's. Curcumin is just an ancient Indian herb that has been studied for many years for its antioxidant and anti-inflammatory properties, as well as its lipophilic property. It can be used to help early diagnosis and even possible treatment of Alzheimer's. The herb is lipophilic, which means that it's able to cross the blood-brain barrier, which is important while studying the eyes because it is allowed to get into retinal circulation and bind directly to those amyloid plaques in the retina and the brain. Its anti-inflammatory properties are important because they reduce that chronic inflammation, contributing to the breakdown of the nerve cells, therefore slowing the loss of cognitive function and nerve cells. There was a study done by the Indian Academy of Neurology on the effects of curcumin on Alzheimer's disease, and the insert is found in that journal down to the left. And what they found out was basically that the levels of beta amyloid in the mice that they were testing were given in low doses of curcumin, and the curcumin decreased those levels of beta amyloid by 40% in comparison to those mice that were not treated. In addition, they found that low doses of curcumin also caused a 43% decrease in the so-called plaque burden that these beta amyloids have on the brain of the mice. Basically, they just found out that the curcumin was breaking up the existing amyloid plaques. Now, while this was done on mice brains, and it cannot be directly associated with human brains, I think that we are on a step or a new frontier of finding possible new treatments for Alzheimer's disease. Curcumin can also be used just to help aid in early detection. Lucky for us, the herb fluoresces in certain lights, which allows us to use it to label those plaques and detect them in the retina. This allows for a high resolution and, more importantly, a non-invasive way to visualize the plaques in the retina. Current studies have also been tested on the technology in mice, as I mentioned before, in that Indian Academy of Neurology, and they found that the early detection studies in those mice were 100% sensitive and 80.6% specific. What that means to us is that it tested positive. All people or all mice who had the disease tested positive, and most people without the disease tested negative. So that proves to be a pretty safe test for early detection. Now, the safety of the drug in and of itself, or the herb, it is natural and safe when used as a diagnostic tool and when used limited. Chronic use can have some problems such as liver toxicity, and that's usually if you exceed about 10 grams per day. So as long as you stay within those 10 grams per day, it's typically considered a fairly safe herb. Now, it can interact with other drugs such as NSAIDs, risperidone, and blood thinning agents. So if patients are currently on those, you might want to communicate with the PCP and see if there's any way that they can get off of them for the early detection studies, or if you should go another route. The Herb is also not recommended for people with biliary tract obstructions, gallstones, obstructive jaundice, and acute biliary colic.
All right, so just to wrap this up, we're going to talk a little bit about how we can change the lives of those with Alzheimer's by just making adjustments in their homes and maybe even where they work, or just things like that. So one thing that we can do as healthcare professionals is educate our patients on these things. So increasing the lighting will help them to be able to see certain objects and avoid bumping into things. Natural light is best. Obviously at night you can't have natural light, but avoiding just really harsh lights, yellow lights, things like that. Avoid patterned carpet and upholstery. Florals specifically are confusing compared to geometric shapes. Probably avoiding any type of shape at all and just having solid colors just helps people find the floor and differentiate it from furniture. Eliminating clutter on the ground is going to help them prevent trips and falls or losing things. So just making sure their house is really tidy and everything is put where it needs to be. Alzheimer's patients have an increased light sensitivity, so just reminding them to keep sunglasses on them and to wear their sunglasses. Color contrast, just to go along with the patterns and such. It's important to have their dishes to be brightly colored and their utensils just so that they can be able to see it in contrast with their food and the table. It'll just help make things easier. And this goes for the same thing for whenever they're picking out glasses. It's sometimes if they like the color red, let them pick out a red pair of glasses and they'll be less likely to lose them. And these are our references. Thank you.